ask any questions, and we'll address some of those at the end of the talk. This shouldn't take too long. Today we're going to talk about atrial fibrillation. It's a pretty complex rhythm and topic to talk about. So this talk is aimed more at an introduction or a brief overview of atrial fibrillation. It allows one to discuss management options with their cardiologist or electrophysiologist. So you'll have a broad background of what atrial fibrillation is and the management for it. So let's see, it's working here. There we go. All right, so we're going to start off with defining what atrial fibrillation is. We'll talk a little bit about the common symptoms, the risk factors that lead to AFib, and then the diagnosis and the treatment of AFib. So what is atrial fibrillation? So it's an irregular heart rhythm where the top chambers of the heart, the atria, are beating chaotically. And so your heart lacks the synchrony between the top and the bottom chambers, which are called the ventricles. So atrial, meaning the top chamber atria, and then fibrillation, basically it's just shaking. And so this diagram kind of illustrates what atrial fibrillation is. So we'll start off with the normal heart here. This top cartoon is a diagram of the heart. It's a picture of the heart where we've just cut the heart in the middle, so it's kind of cut in half. And so to orient yourself, these are the top two chambers called the atria. This is the right atrium and the left atrium. And these are the bottom chambers called the ventricles. And so in a normal heart rhythm, the heart rhythm is controlled by an electrical signal. And so the signal starts in the sinus node, and that's the actual normal pacemaker of your heart that everyone is born with. So the signal starts there and it travels along the top chambers of the heart, along the atria.
Sure, we're on, but he's showing things and we can't see it, so.
Oh. Can no one see my screen? I just heard someone say they can't see anything.
I can see it.
Okay, we're good. Okay.
We can see it. We can see it.
Okay, got it. So I'm going to keep going then. So the top chambers get the electrical signal and they squeeze. And so that electrical signal in the top chamber corresponds on the EKG, which is down here. And so that is the recording of the electrical signal that we get from leads on your chest. And so if we look at this one area right here, this is one beat of the heart. So this little blip that you see in the beginning, that corresponds to the atrial activity of the heart. So that's when the top chambers get the electrical signal and beat. After the top chambers get the signal goes to what's called the AV node. It's kind of the junction box of the heart that it delays the signal a little bit, allowing the blood to go from the top chamber to the bottom. And then that signal splits up and it goes to both the right and the left sides of the heart together and allows the bottom chambers to squeeze. And that's what squeezes blood and moves blood out of the heart to the rest of the body. And so the ventricular activation or the electrical activation of the bottom chambers corresponds on this EKG to this really sharp spike. And so if we look at this rhythm, it's very organized. You have a very distinct electrical activity in the top chamber, and then you have the ventricular chamber after it. And it's very organized, predictable, and synchronous. Compare this to this side. So this is when a patient is in atrial fibrillation. So in this patient, something has triggered their top chamber to go into AFib. And so instead of the regular pacemaker controlling the rhythm, this patient has just areas in the top chamber are all kind of firing activity, electrical activity, all at the same time. And so nothing is really controlling or driving the top chamber. So instead of having a nice coordinated squeeze of the top chamber will just kind of shake, it won't squeeze. And so if we look at the EKG, now instead of having that really distinct signal corresponding to the atrial electrical activity, it just looks really chaotic. It looks really messy. And so that's just the top chamber just shaking. And then whenever one of those signals gets to the bottom chamber squeezes. So you still have that really sharp spike from the bottom chamber, but now it's not very rhythmic. You can't predict when it's going to happen. It's very irregular. And sometimes, like these two beats, they're really fast. They're really close together. And so that just indicates that their speed can be really fast. Your heart's beating extremely fast and irregularly. And so atrial fibrillation is the most common sustained arrhythmia or abnormal rhythm in adults. So it's not uncommon. It actually occurs in up to 37% of individuals above 55 years old. So it's pretty common as you age. The issues with atrial fibrillation, besides the symptoms that we'll talk about, is an increased risk of blood clots, of stroke, and of heart failure. Heart failure is basically when the heart isn't pumping well. The heart's a pump. Its job is to fill up with blood and squeeze blood out to the rest of the body. And for whatever reason, if the heart's not able to pump blood adequately to supply blood to the rest of the body, that's called heart failure. The way we classify atrial fibrillation is based on the duration of time that patients are in it. So it starts off with what we call paroxysmal or occasional atrial fibrillation. That's someone who has AFib for less than 7 days. And some of these people will go in and out of it. They'll last for a few minutes or a few hours, and then they'll come out, they'll go back into it. If it lasts a little longer, so if it's more than 7 days, we call that persistent atrial fibrillation. If it lasts even longer than that, more than 1 year, that's called long-standing persistent. And then if it's to the point where medications aren't able to control it, other treatment options aren't able to control or get patients out of AFib, one may opt just to stay in atrial fibrillation, at which point it becomes permanent atrial fibrillation. These aren't separate entities. It's probably more of a continuum. So patients start off paroxysmally going into AFib, so it's coming and going. As they have atrial fibrillation, what we say is AFib begets more AFib. So they have a lot of changes that occur in the top chamber of the heart that promote more AFib. So then those people they'll stay in AFib longer, they'll start having more of it, and they may start having more symptoms. And so the treatment of AFib is usually targeted early. As you have more AFib and stay in it longer, it becomes a little more difficult to get you out of atrial fibrillation. The symptoms can be really various. Some patients have no symptoms at all. Some patients may go 10, 15 years and not know that they're in AFib. Some patients are on the other spectrum. They go into atrial fibrillation, they can say exactly when they went into it. They have palpitations, they feel like their heart's racing, it's irregular. They can have chest pain or dizziness. And some people will have kind of a progression of symptoms. They start becoming more fatigued, more weak. They're getting more short of breath doing things that they normally could. And so those are some slow progressive symptoms that they can have. So it really varies among patients on what kind of symptoms they have. The risk factors for AFib, there are some things that are treatable or reversible. Patients who have a heart attack, have thyroid disease, lung disease, who've engaged in heavy alcohol intake or recently had heart surgery, a bypass surgery or valve surgery, those patients not uncommonly will have atrial fibrillation around that time. And so getting them out of AFib and then treating those symptoms those patients do really well in not having much more AFib after that. There are some other risk factors that aren't necessarily going to go away. And those are things like age. As patients age, they have a higher risk for developing atrial fibrillation. Things like heart failure or heart valve disease. Some valves, as they become tighter or they become more leaky, that promotes atrial fibrillation. Chronic issues that patients have, high blood pressure, diabetes, kidney disease, all of those things contribute to developing AFib as well. And something we probably don't diagnose as much as we should, many people do ignore this, is obstructive sleep apnea. And so I think that's a very important illness to treat. A lot of patients will have atrial fibrillation because of untreated obstructive sleep apnea. So I think that's something that everyone needs to be aware of. And so the diagnosis of AFib is made based on ECG or electrocardiogram. So that's the electrical tracing of the heart. It's usually done in clinic. And so that gives us kind of a snapshot in time of what your heart rhythm is doing. Sometimes people who, especially people who go in and out of AFib, we're not always going to catch it right when you go into clinic. So we may order what's called a Holter monitor or an event monitor. Essentially what that is, it's a little monitor that sticks onto your chest, and it's checking your heart rhythm continuously from usually 24 hours to up to a month. And so that can catch atrial fibrillation that's maybe coming and going, people who have it maybe once a week or twice a week. It's able to catch that much more. What your cardiologist may also check is an echocardiogram or a stress test to see kind of if you've had any effects on your heart from AFib, or what there could be that could be contributing to you developing AFib. And so the treatment of AFib, there's kind of a two-pronged approach, and you can't ignore one of them and just treat the other. You kind of have to tackle them both. And so the first is stroke prevention. And the second is to treat either the rhythm or the rate. So when you have atrial fibrillation, there is an increased risk of stroke. And so the treatment for that is blood thinners. And so what we want to do initially is risk stratify. Not everyone needs to be put on blood thinners straight away. So we look at different factors that contribute to the increased risk of stroke. And those, and you essentially get a point for each one of these. So someone who has heart failure or high blood pressure, they'd get a point for those. Someone who's more than 65 years old, they get a point. Someone with diabetes or a prior stroke. Having a prior stroke is a much higher risk for having another one. Those who have vascular disease, meaning they've had a heart attack before, they have disease of the vessels in their legs or carotid artery disease. Those who are above 75 years old, they get another point. And then female patients get a point too. So if you have more than one of those risk factors, your risk of stroke is high enough that you would benefit from a blood thinner. Generally, blood thinners we use are things you may have heard of. There is apixaban, and then there is rivaroxaban. Those are two of the more common ones for non-valvular atrial fibrillation, meaning atrial fibrillation that's likely not related to valve disease. In those who have valvular disease, who have had a valve replacement or have disease of the valve that could be contributing to atrial fibrillation, we use Coumadin or warfarin. The one downside of using that medication is we need to check levels of your blood to see if your blood's thin enough, and there are some dietary restrictions with that. With the first two, we don't have those issues. So that's the stroke prevention arm of treatment. The other arm is to treat either rate or rhythm of AFib. So traditionally, they were regarded as probably being equivalent. More studies have shown that's probably not the case. So with rate control, the goal is to treat the heart rate in order to control the symptoms. So the heart rate's not too fast, and we want the heart rate to be a manageable level while you're at rest or doing activities. And so we use medications. These are commonly used medications: metoprolol, carvedilol, diltiazem, or digoxin. Some patients, instead of having a really fast heart rate, they may have a really slow heart rate, or they kind of go back and forth. When they're not on medicines, their heart rate's really fast. Putting them on a small amount of medicine, their heart rate gets too slow. In that case, you may need a pacemaker. The other option is rhythm control. And the goal of rhythm control is to keep one in a normal rhythm. And so a lot of studies now have shown that early rhythm control has many benefits compared to rate control. We've shown a decrease in mortality from cardiovascular causes, stroke, of hospitalization for heart failure, or acute coronary syndrome. So patients do really well with early rhythm control, especially if we're able to catch this when it's early, as in paroxysmal, or it's not been going on for years and years. And so the first step in getting one out of atrial fibrillation, we usually start with cardioversion, and that's an electric shock to the heart. It's a safe technique that gets someone out of AFib. So it gets you out of AFib, it doesn't really keep you out of AFib. The way I like to think about this is, if there's something wrong with your laptop or your phone, you turn it off and you turn it back on. That's essentially what we do here. It doesn't mean that you can't have AFib 10, 15 minutes from then, but it gets you out for now. And so that's where the next issue comes, maintaining normal rhythm. And so we have treatment options for that. We have medications, antiarrhythmic medicines that we can use, and based on other issues that one has, are they diabetic, do they have renal disease, do they have heart failure, that can drive which medications we can use. There are also procedures we can perform that can decrease your chances of having atrial fibrillation once you have it. And those are things that can be either surgical or minimally invasive, and it's called an ablation procedure. And so basically a catheter ablation, and this is what, as an electrophysiologist, this is what we do. We do minimally invasive procedures that take a few hours to do. And so one of those is catheter ablation. And so basically what we're doing with ablation is, ablation just means applying heat energy or cold energy to the heart muscle in order to create a scar in a very specific location. And so with AFib, earlier when we talked about the AFib, when I showed the diagrams, we said something triggered that patient to go into AFib. So what we've seen in a lot of patients who go into AFib, who have AFib on and off, it's related to an abnormal electrical signal that comes from the pulmonary veins. So again, if we look at this diagram, reminding you this is the right top chamber, this is the left top chamber. And so these little holes, those are the openings for the pulmonary veins. These are the pulmonary veins. They're the veins that take oxygenated blood from the lungs back to the heart to be pumped everywhere else. So these veins have a little bit of a muscular connection around them. And in some patients, and again, this is a very complex thing that we don't know the entire answer to on who exactly is going to have this and who isn't, but in some patients, that area becomes very arrhythmogenic, or an area that can promote abnormal rhythms. It's electrically kind of irritable. And so when we do an ablation, essentially what we do is we create a scar around those veins. That does nothing to blood flow. Blood will flow through those veins and into the heart, through the heart normally, but the scar blocks any electrical activity from crossing it. And so those abnormal electrical signals coming from those veins don't make it to the heart. So we're decreasing the triggers that get people into AFib. And patients who've had AFib longer may have triggers that come from other places too. So we look for those areas and we do an ablation in those areas too. So the way we do ablation is either with heat energy or with cold energy. Heat is called radiofrequency and cold is cryoablation. And essentially it's this little catheter, it's like a wire, a little bit thicker than the wire. And we create a model of the heart and then we apply heat energy to the area around the veins. And we basically draw a circle. And so that creates a continuous scar around each one of those veins. When we use the cold energy, it's a little balloon that fills up with really cold liquid. And so whatever we push that against freezes. And so we push it against the muscle around those veins. And so it creates this continuous scar based on that area being frozen. We leave it there for a couple of minutes and then we come off. And then we test in either of these cases to make sure that electricity doesn't go back and forth. And that's how we test to make sure we have block there. These two techniques are equivalent. And so some people prefer using the heat energy, some prefer using cold energy, but in treating atrial fibrillation, they are equivalent. There are other technologies that are becoming more available or being developed, but they are not very common right now, so we won't really talk about that too much. And so usually when we do an ablation, we start off with some imaging of the heart. And we usually start off with a CT scan that gives us a 3D structure, a 3D model of the patient's heart. So this is an actual 3D model of this patient's heart. And so we're starting off looking kind of directly at the patient. So they're facing us. And so what we see here is the right bottom chamber. And as we go around, we're seeing the right top chamber. And then we're getting to this pink structure here. That is the left atrium. And what you see is, you see these branches coming off. Those are the pulmonary veins. So those are the structures that we target for ablation, to ablate around. And so this is a map during the procedure. We create another map from inside the heart. And this is just that map rotating, and you can see the left atrium, the left top chamber, and you can see the veins coming in and out. And then this is essentially what it looks like once we're done with the ablation. You can see these little red dots, and that's where the heat energy was applied, and we create a continuous circle around it. And then we make sure that electricity doesn't travel back and forth. So that's essentially what an ablation procedure is. It's safe and effective in decreasing atrial fibrillation burden. And a lot of new studies have shown that it's more effective than medications, especially in patients who have paroxysmal AFib. So those patients that go in and out of it, this does a really good job of treating that trigger to help decrease how much AFib you have. Now, it's not a cure. There's no cure for AFib. These are all management options that we have. So the goal is to treat it and decrease it. And the goal is to try to interrupt or delay that progression from paroxysmal to more persistent and long-term persistent AFib. And ablation is also a good choice for those who don't really tolerate antiarrhythmic medications well. And so that was kind of a brief overview of a fairly complex rhythm. And so atrial fibrillation, it's a common arrhythmia. We see this regularly, and it's rarely fatal, but untreated AFib can cause a lot of serious issues. It increases one's risk of stroke, of heart failure, and that's aside from all the symptoms that one may have when they're in AFib. Adequate treatment of their chronic medical problems can decrease the risk of having atrial fibrillation. So it's extremely important. Treating high blood pressure, treating diabetes, making sure you're taking your medications well. All of those things help decrease the chances of having AFib. Those who do have AFib, preventing stroke is extremely important. So taking blood pressure, taking anticoagulants or blood thinners, if you are at a high risk of stroke, is extremely important. And then the treatment of AFib includes many, many treatment options. Those include medications and then procedures, catheter ablation. In some patients with long-standing atrial fibrillation, a surgical ablation may be beneficial too. I didn't really go into that too much, but it's more of an invasive surgical procedure. And at times, a pacemaker implantation may be required if the heart rate's getting too slow or issues like that. But these are all options and management techniques that one should discuss with their cardiologist or electrophysiologist and kind of tailor to their needs and their requirements. So that was my summary. Here's some resources on atrial fibrillation. Our website has a lot of good information. There's a website from Abbott that has a lot of good educational videos, introductory things, and then the Mayo Clinic has some good introductory educational material too. So those are good places to start. If anyone has any questions, I'd be happy to address those.
I do.
Yeah, go ahead.
I do.
Go ahead.
I have a question.
Yeah.
How do you choose whether you're going to do the cold or the hot when you do an ablation?
Yeah, that's a really good question. So a lot of times, again, they're equivalent. So let's say someone has paroxysmal atrial fibrillation. They're going in and out of it. In those patients, a few things that could help. So when we use the cold energy, we have to give a little bit of IV contrast. So those patients who have either allergies or any kidney problems, we may say, let's not do that. Let's use the heat one. Otherwise, it can be kind of either or. In patients who we expect to have other triggers, and it's not just the veins, and we maybe need to target other areas, in those patients, we'll use the heat energy as opposed to the cold energy. The cold energy is basically for the pulmonary veins, and that's it. But if there's any other areas, we have
the cold energy.
It's for the pulmonary veins, that trigger that comes from the veins in the heart. That's what the cold energy is for. The heat energy can actually target other areas if needed. It's not as common. Usually we start off with just the veins when we do an ablation, but someone who's, let's say they've been in AFib for a year, for 2 years, they may have other areas in the heart that could be triggering the AFib. And so in those patients, we'd use heat energy because we can target other areas too. Yeah, that was a really good question.
Okay. I had one. I just don't know which one it was.
Okay. All right. Any other questions?
I have a question.
All right, great. Go ahead.
So I'm one of the patients at VCS, and the electrophysiologist I see did not want to do any ablation. He just wanted me to take Sotalol and Eliquis. So, and I never really understood why that would be.
That's a good question too. So a lot of times patients who've had, like, let's say you've had one episode of AFib, we'll try medications first. Other issues could be if you've been in AFib for a long time, or as you have more atrial fibrillation, what happens is the top chamber of the heart becomes more dilated. It becomes kind of scarred and dilated. In that situation, an ablation isn't always, it's not going to be as successful. Generally, the medications do well in that situation. Usually how I like to think about it is it's kind of like having a fire, right? So you have the firewood and you have the spark that starts the fire. And so as you have AFib, the triggers are kind of the spark, and that's what we go after. But the heart muscle itself is like the heart is the firewood. So as you have more and more AFib, you have more scarring in the top chamber, and so you have more firewood there. And so eventually what that happens is that top chamber itself promotes more AFib. And in that situation, it may you may still require medications even with an ablation. Now, in your situation, I'm not exactly sure what would be preventing the ablation, but that's something to bring up. And
I think he said he wanted to save it.
Okay.
For later, if
and
the progression.
That is one approach for this. A lot of the studies for ablation are coming up now, so they're newer. Like I had said initially, the treatment options were thought to be equivalent with keeping people in AFib and just controlling their rate, or getting them into a normal rhythm. What we found since then, over the last few years, is that getting people into a normal rhythm is probably much better. And now we're trying to tease out, is ablation better or is medication better? And most likely it's going to be somewhere in the middle. It's probably going to be a combination of the two. And so there's that. I hope I answered your question to some extent.
Yes, thank you.
Okay, absolutely. I did get one question on the chat. How is atrial flutter different from atrial fibrillation? So atrial flutter, it's kind of a cousin of atrial fibrillation. Usually someone who has one is going to have the other at some point, or is at a higher risk for it. So with atrial fibrillation, the top chamber is just kind of firing erratically. It's really chaotic activity. With atrial flutter, the way that's different, it's more of a circuit that develops in the top chamber. It's kind of a short circuit. And so that's a really predictable rhythm and a predictable circuit that we can use catheters and actually map. The thing with atrial flutter is a lot of times if we can do an ablation for atrial flutter, that can actually help that specific flutter not come back. AFib, we can't really say that, okay? AFib's still a really complex rhythm where there's a lot of things at play. So we can't really say that we're going to do an ablation or put you on a medicine and you're never having AFib again. The goal is to decrease how much AFib you have and kind of delay or interrupt that cycle where it becomes more persistent. With atrial flutter, patients do really well, and we're actually able to stop that from coming back in a lot of those patients. A few more questions. Can aortic stenosis contribute to atrial fibrillation? So sure. So with aortic stenosis, you've got an obstruction to blood flowing out of the heart. So essentially what that's doing, it's overloading the heart muscle itself. Your heart's straining a little bit more, and so the pressure inside the heart in the bottom chamber and eventually in the top chamber, because all of that pressure goes backward, is going to increase. So I'm sure it does contribute to AFib. So usually with those kind of issues, treating the valve issue may help decrease how much AFib you have. So yeah, I think there is some contribution. And the other question I had was, is sleep apnea and obstructive sleep apnea the same thing? So for the most part, yes. So sleep apnea, we generally think of it in two different types: obstructive and central sleep apnea. So obstructive sleep apnea, it's basically when you're asleep, the tissue in the back of your throat kind of falls back and covers the airway. And so you get an obstruction to the airway. And so a lot of people don't wake up. Some people will snore. When they do wake up, they just feel tired all the time. And so essentially what's happening is that when you're asleep and you're obstructing your airway, your oxygen level in your body's dropping. You're becoming hypoxic, and so your body's undergoing kind of a high stress situation, even though you're asleep. And so that high stress promotes AFib. And so central sleep apnea is a little bit different. The treatment for that is probably a little bit different, but it probably has the same effect. It's just the treatment's different. Usually when we talk about sleep apnea, we're talking more about obstructive sleep apnea. That's the more common one. And so treatment with a CPAP for that is what's beneficial. So, yeah. Any other questions? You can unmute if you need to. I think everyone has the power to unmute now. Okay. Was that it? There's one more. Okay.
Can you see how much scarring has been done about that when AFib has not been diagnosed?
Not when AFib has not been diagnosed. So a few ways we check for the scarring. So the first thing, the non-invasive way to check for scarring, especially in the top chamber of the heart's kind of a thin muscle layer. So we usually start off with an ultrasound of the heart or an echocardiogram. So as you get more scarring, the top chamber of the heart becomes dilated. So it becomes really big. So if someone comes in and their top chamber of the heart's extremely big, and then they're complaining about palpitations, their heart's racing sometimes, even if they're in a normal rhythm when we see them, the chances are that they've probably had some atrial fibrillation. The more invasive way we check for scarring, and this is something that we do especially during an ablation, is we do check the voltage inside the heart, and we look for scarred areas or abnormal electrical activity. So those are some of the things we look for scar. But the thing that really drives it in someone without AFib is how big the top chamber is. A lot of things that contribute to that. It's not just atrial fibrillation, but having valve disease, having mitral regurgitation or mitral stenosis, having coronary disease. You can have some dilation of the heart, having heart failure, especially if it's not treated well, or if you've got a lot of pressure in the heart. Those things can cause the top chamber to become dilated. How much scarring there is from that type of dilation, it's hard to tell, but that's usually what we go with is the echocardiogram. Yeah. Okay.
I think I'm sending out the slides to everybody.
Okay. All right. So we're going to send out the slides to everyone. So everyone should have those. And there's some resources there. But if anyone has any other questions or concerns or anything, feel free to contact any one of us at VCS, and we'll definitely help you out. But thank you guys for coming and listening to us talk. I really appreciate it. Hope everyone learned something.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.